video I would like to introduce to you the computerized occlusogram. What is the occlusogram? The occlusogram is something that we do in order to define as much as possible in details which are the treatment goals of our orthodontic treatment. In the orthodontic treatment, I would say that the definition of a 3D treatment goal is of extreme importance. And it's the first step you do in all cases where you need a very well-defined treatment, and if you want to achieve as much as possible predictable results. So I have to say that the Occlusogram software is something that I use in all of my cases where a specific definition of the dental movements is needed. And as you see here in my orthodontic treatment planning, we include different stages, but the first stage is the definition of the three-dimensional treatment objective. So after that we can define what is the necessary force system, then we start thinking about anchorage, we start thinking to treatment stages, and definitely we start thinking, and finally we can start to think about our appliance selection, appliance design, and so on. But let's talk now about the definition of a three-dimensional treatment goal. Actually, when you start a treatment, an orthodontic treatment, you should define as a goal two things. The first part is to define the position of the mandible. Most of the time, the position of the mandible is not to be changed, at least in adults, patients. So this step in many cases is not to be done. But there are cases where you predict growth, or you are considering surgery, or you are considering changing the position by the mandible by altering the condyle's position. And so in these cases you should consider that the mandible is moved somewhere else, and this is the first step of our treatment goal. Once the mandibular position is defined, only at that time you can start defining the treatment part that is involving the dental movements. So the second goal is to define the needed dental movements, and here we use the occlusogram. The occlusogram is a wonderful, very powerful tool that helps us in finding out which are the needed dental movements. So I will give you a short history of occlusograms, a list of a part of it, because many people have been using these terms but developing different procedures by the analysis of the occlusal view of the models. And the person who has expired first the occlusogram, as I see it now, was Bjork. In 1968 he worked with the occlusogram in order to demonstrate fascial growth, and he was trying to put into relation the dental casts with lateral cephalometric, and in that way he just gave the first basis to the development of the occlusogram as we know it now. And later on, Marcotte defined a procedure in order to combine together the occlusogram, so the occlusal view or the drawing of the occlusal surface of the models with the lateral cephalometric. All this was done manually, and Professor Burston in 1979 developed a first software that was able to reproduce the same procedure with the computer. But you can imagine that at that time the capabilities of computers were very limited, and especially these computers were not spread among the people. So orthodontists didn't have the chance to use computers to execute the occlusogram. And I can tell you, since I've done it for many years, that manual procedure is rather time consuming and takes a lot of effort. And so for this reason, I think that at that time the occlusogram procedure was very much limited to few people who wanted to work with this tool. In 1980, Professor Bill Melson used the combination of the occlusal view and the lateral cephalometric in order to help her design of orthodontic mechanics. And also she was using the occlusogram in order to check the results she could obtain by her treatment and compare them with the treatment goal she had set at the beginning of the treatment. I started working at the project several years later, and in 1995 we had already developed what we call the orthodontic calculators, that are software that we have further developed later on. But this software were capable of making vectorial calculations, were capable of analyzing the dental movement and finding out the needed force system. And so we were using this orthodontic calculators together with the occlusogram in order to generate a mechanical analysis of what we were planning with our dental movements. In 1998, I have published a paper on the American Journal of Orthodontics that was called T3DO Occlusogram, in which I described this procedure, and I also described the first computer software that I had developed. At that time, the computer software was just repeating the same manual procedure, it was just a little bit faster, more accurate, but basically was exactly the same thing as we were doing before with the manual procedure. In 2005, things started to change because we had available the digital models, and I started using the digital models at that time, and this made a lot of changes for the speed of the procedures and the quality of the occlusogram, but moreover, it gave to me the possibility to develop furthermore the occlusogram and to go to the next step. That was a real true 3D occlusogram, so we called it T3DO Occlusogram. That was released in 2008, and with this software we really had the possibility to develop a treatment plan that was involving all dimension in the space. So now we could ask ourselves, well, what is this occlusogram, or at least the classic occlusogram? So how the occlusogram was until 2005. And this is a system where you give some input, and then the software is going to work with this data you give as an input and give you and the software gives you some output that you will have to evaluate. So at the beginning you have to ask yourself which are the inputs that we need to give to the occlusogram, and they are basically what you see here in this slide is the dental size and the possible changes of the dental size. This includes also extractions or IPR or build-up of teeth or space creation for prosthetics or implants. And the second point will be the symmetry axis. The third point, the desired position of the front teeth. And the fourth point is the transversal size of the arch at molar and premolar level. And then you also give some information about the convexity in the canine area. All these inputs are given to the software, and here you see the step where we have the measurements of the teeth. Actually, if you use our system with our digital models that comes from OrthoLab, all these measurements are already in the models, so you don't have to measure anything. You can check it and remeasure if you like it, But when you open this window, you see all the measurements in millimeters and with decimals that are already listed here. You don't have to do anything any measurement at all, unless you have some doubts or some measurements and you want to check it again. Here you see that you have the size of the teeth and another column to the right, which is all listed with 0, and here you put the variation. So for example, if you want to extract a tooth, you will place here minus 7.2 for the extraction of 1 premolar, of the 1.4 premolar, or if you want to make an IPR, you will place minus 0.2 or 0.3 in millimeters. That's the amount of IPR you're going to do. And all this is used later on for the occlusogram construction. Then there is the symmetry axis. The symmetry axis is a very complex topic that we don't have the time here to explain in depth. Just imagine that you build up your occlusogram on a symmetry axis that in the anterior part should be crossing the facial midline. And this is a very simple choice most of the time in symmetrical cases, but at least skeletally symmetrical cases. But sometimes you have problems in these cases, in cases of asymmetries, and in these cases the choice of symmetry axis become critical, and it's actually your decision of treatment. It's mostly based on the symmetry axis that you have chosen. And here there are some example of symmetry axis that you can use. This is a very symmetrical upper arch with some asymmetry in the lower, but you might decide to alter the symmetry axis. This means, of course, it's just a provocation to let you say this. It means that you can keep the same anterior reference, but changing the posterior so that you will have a sort of rotation of the whole arch, we really don't have the time to explore this topic, which is of fundamental importance in the treatment planning of symmetrical cases. But I would say that this is beyond the goal of this presentation. The other thing you can decide is the change of position of the front teeth. So what you say is, okay, I have the front teeth here that are described by the red contour, and I want to create some extrusion or want to retract a little bit lower, and then you draw them with the green contour. And this is considered in the developing of the final dental arches. Then finally, you define the transversal size of the dental arch in the upper and the lower. So the system will build up two arches that are well coordinated. And what you have to choose is the transversal dimension here at molar level and here at premolar level, and the convexity of the anterior curvature. How do you decide this? Most of the time the decision is taken by a clinical observation. Of course, you can have some average measurements for the transversal sizes of the arch, but I would suggest you to observe the smile of your patient and decide whether your arches do requires an expansion or not. So in these cases, you see patients with different smiles, and you see on your left side a patient that requires a lot of expansion. A little bit of expansion could be needed in the face in the middle, while no expansion is needed in the right side. So when you have given all these inputs, what you have is a partial reconstruction of the structures of the patient in 3 dimensions. Actually, we are combining the lateral view of the cephalometric with the occlusal view of the plasters, but That's what we get out from the classical occlusogram. And here we have a lot of information that can be seen in an occlusal view. For example, here you can see in this arch, you see all these dots with different colors represent the final position that is planned for our teeth at the end of treatment. And here, for example, this blue dot here near the cursor, it's the final position of the mesial contact point of the first molar. So this means that the first molar here on the left is going to be expanded and a little bit mesialized. Just remember that this line of the arch should be passing through the central groove of the posterior teeth. So here you see, for example, that on the right side we have a major expansion needed for tooth 1, 6 and 1, 5, and a minor expansion here for this teeth. And also you see the movements which are asymmetrical for the anterior teeth. Actually, this is a case where we are planning a reopening of a space in this area because there is a missing premolar. Here you see the teeth represented by these segments in their initial position, and so here you can see very well which is the needed movement on the occlusal view. So for what is our occlusal view, we have a very good definition of our treatment. And here we work a lot, and we can work finding out also the needed force system. We can work and thinking to the anchorage problems, and also the occlusogram can give us which is its prediction of the final intermaxillary relations. And here you see these two arches where the interproximal point of contacts are represented, and you see that here on the side we have a very nice class 1. This is the lower molar mesial point, and this is the upper molar mesial point. And you see here a nice class 1 is represented. Maybe here we have a little bit of class 2 tendency, but in the overall we have a nice intercuspation of the teeth. So in this way you have some information that comes out from the occlusogram, and that's the method we use with the occlusogram. So we take a decision to do something, we give this input to the computer. The software will process our data and gives an output, and we evaluate this output. So we can decide, is this output satisfactory or not? If it is not, we change our decision, give new inputs, new process and output, and we have a new evaluation until we are satisfied with the output and we go to the final treatment goal. This is what we call an iterative method. The advantages of classical computerized occlusogram are more precision. Definitely it's faster, and we can have more speed in execution of the occlusogram. And it's very fast also to exploit alternative treatments. So you can see, oh well, this case I think it can be done both with extraction or non-extraction, or expand more, expand less, or maybe you define different symmetry axis, and the computer in a matter of seconds tells you what happened if. So this is very, very fast. Basically, it gives you the same results as we were doing with the manual procedure. And another thing which is very interesting is the integration with the DMA software, the software that now we use and has taken the place of what we were calling before the orthodontic calculators, and this is also very important in designing the mechanics. So with the classical occlusogram, we get the needed mesodistal and baccolingual displacement for all teeth. We find the rotations for all teeth, and vertical displacement and torque for the front teeth groups. But we miss a lot of things. We miss the needed vertical displacement for all teeth, for the posterior, and also for the front teeth. If you think to a selective, for example, you cannot say with the old occlusogram where if you need a selective extrusion of a lateral incisor, that was not possible. We miss the mesodistal inclination for all teeth. For example, no way to analyze a mesial inclination of a molar, and we couldn't see the torque of the posterior teeth. So all this is now performed with T3DO Occlusogram, and this is the new step that we have been able to work with in the later stage. So with the introduction of digital models and of the T3DO, we could analyze our problems and our dental movements by any perspective. And so now what you see are the digital models themselves, and they include two arches at the end of the occlusogram procedure. And these arches show where is the final needed position of the interproximal point of contact of both arches. So since you can rotate the models together with these arches, you see in three dimensions, as you see here, the movement, or at least what are the needed movement for every single tooth. In order to get these results, we have to give other inputs, and especially we have to define which is the vertical position of the lateral teeth. So here you see these arches that are defining at which level are the interproximal point of contacts of molars and premolars, and also the shape that here is describing the position of the anterior teeth, which is definitely correlated with the curve of Spey. So as an output, here you can see that in 3 dimensions we can see movements that with the classical occlusogram were not possible to be seen. Here, for example, you see this expansion and intrusion of the upper premolar, expansion and extrusion of the lower premolar. Of course, the vertical movements that are described here were not possible to be seen in the classical view. And the same is the selective intrusion of the lower incisor. And so the selective extrusion of these upper incisors, and here in the lateral view, this intrusion of the molars. So all these movements are only possible to be analyzed, to be described with the T3DO occlusogram. And once you have done this 3D arch, when you have it available, then it's very simple just to have it as a guide for a virtual setup. Actually, we're doing this. And here you see it, our digital models with the virtual setup, and you see all the teeth that are being moved to a final position. And but at this moment we are performing a manual movement of these teeth on the digital models. But quite soon we will probably provide an automatic setup based on the occlusogram output. So what's next? Yeah, the weak point maybe at this time is the lack of a connection with the CBCT. And actually you can do it, but it's something that you have to work a little bit on your own and try to find out from the CBCT which are the needed vertical movement in the posterior teeth. So probably what we will need is just to connect the lateral view. As we were connecting the lateral view to the occlusogram, we will need also to connect the front teeth, or maybe different layers of the front view to the digital models. So in this way, as you see here in this image, we can have a true reference for the height of the posterior areas. And so by working together with the occlusogram and CBCT, we can really get a very sound and reliable treatment planning, also for cases which are quite complex, like, for example, skeletal asymmetry with vertical and transversal asymmetries. And also with the CBCT, you can evaluate the inclination of the teeth in considering the long axis here, because you can see the roots, and then you can make a better analysis of the movement in 3 dimensions, considering the correction of the long axis of these teeth. And so here you see the possibility that we will work very soon in order to get connection between the CBCT and the digital models. One other thing that is available already at this moment is the possibility of using a virtual articulator. And we use this virtual articulator that is available on the software that is released by Ortholab with the digital models. And by doing this, we can simulate condylar repositioning or even growth, or even surgery. And with repositioning of the mandible, we create new models, and these new models can then be used for the occlusogram. And then from these new models, you can again make a new occlusogram and maybe a setup which is based on this occlusogram. So that's what is the occlusogram. That's what we have now, and that's what we are planning to get very, very soon. So if you are interested, please stay tuned with us, and we are willing to get in touch with you. So if you have any request for information, please send me an email at my email, which is giorgiofiorelli@gmail.com. Thanks a lot for your attention.